I'm sorry, I will start the session. Somehow I lost the capability to be able to share. Then we'll figure out.
Yep.
Sorry about this.
I'm going to send all the files to, probably I should, yep. So go ahead, I will work on it here.
All right. Sorry about this. Hello, everyone. Welcome to this panel session, GIS for Community Health. And the purpose of this session is to really offer a platform for us to discuss how GIS spatial technologies can help us to not just understand the health issue, access to health services, but also to connect that to policy and health management. So we do have a wonderful panel here consisting of Dr. Michael Amp from University of North Carolina at Chapel Hill, Dr. Debs Gosh from University of Connecticut, Dr. Russell Kirby from University of South Florida, Dr. Sarah McLafferty from University of Illinois at Urbana-Champaign, and Dr. Joseph O'Pine is somewhere trying to join in, or Joseph O'Pine from University of North Texas. We will find him if he is having trouble joining us here. For sake of time, we're going to do this, go ahead and have all the panelists to give their own speech based on what they prepared under the broad umbrella of GIS community health. And you will hear that some topics are relatively broad and talking about data, scale, and modeling issue, and others may be more applied to some specific topics. And then we will save all the questions towards the end. And Enki is going to help monitor the Q&A section. And so for all the questions, please type the questions using the chat function. Type it in there, and Enki is going to help monitoring that. So since I was going to just do this following alphabetical order. In that case, Michael, Dr. Amk, you'll go first, but sorry, I cannot share screen now. Give us a couple minutes. So if you don't mind, Debs, do you want to go first? And then we'll figure out. So we'll go Debs, Michael, Russell, Sarah, and Joseph in this order.
Okay. Can you hear me? Okay. I'm going to share my screen and see if it works. When I did the practice session, I didn't see myself, so I'm going to only look at the whole screen and just talk, and let's see how it goes. Can you see my?
Yes, yes.
Okay. But this is not the presentation mode, right?
No.
Okay. Okay, so thanks for giving me this opportunity to be part of the panel for GIS for Community Health. Thanks to UCGIS and thanks to Yongmei and Enki for inviting me for this session. So what I'm going to do in my part here is very briefly go over two studies, example studies, which will address some of these issues or concepts or items when we do community health work using GIS or other spatial analysis, like scale, data, engagement, and what's next? How can we sustain community health projects using GIS? So the first example study that I want to talk about is the mobile medical clinic. It includes a mobile medical clinic, and it is focused for the New Haven neighborhoods in the state of Connecticut. It involves a 40-foot community healthcare van, as you can see the picture on the left here, and it travels directly to New Haven's poorest neighborhoods impacted by HIV/AIDS, substance use, homelessness, and mental illness. It overcomes traditional medical care barriers and obstacles by bridging the gap to link patients to medical and social services. And here are some pictures how this mobile medical clinic, or MMC, looks like from inside. And other than going to these neighborhoods, it also has 4 fixed locations in the different neighborhoods of New Haven so that it can reach the maximum number of clients needed from the community. It started from a generous grant, several kinds of grants from National Institute of Health and SAMHSA for the state of Connecticut, and it was started by my collaborator and also one of my mentors, Dr. Frederick Altis from the Yale AIDS program, as well as in Yale New Haven Hospital. So it started around the early 2000s, and as you can see, it is focused on pretty stigmatized health conditions for clients living in this community. Over the years, it did a relatively great job in reaching the communities members, especially who are homeless, who has this double issues of substance use as well as HIV. Along with that, we also did a lot of work from the research point of view. And there is this website here, if you have, in your free time, if you want to know more about this CHCV, or Community Healthcare Van, you can browse this website where you will find different videos with testimonials as well as research coming out from this community-based project. So I don't have the time to go over the video and the testimonials, but I'll just read out these 3 broad missions of this community project. First, be there, which is be there in the community. Second, understand the people with whom you will be in contact. Third, when you do not understand, listen until you do. And finally, remember that you are working in the interest of the person who has sought your help. So this has been the major theme or motivation and a principle of this project here. And over the years, there were several research projects coming out, and one of them was to look at the background of the clients, where they're coming from, why they're coming from, what are their needs. Basically, look at this from the spatial lens. And this is the project that I led in the group, and the study came out in Health and Place a few years back. 3 objectives or research questions we had for this one is examine the spatial distribution of clients, self-reported residents and healthcare utilization patterns, analyze the spatial distribution of clients with very high usage. So there were people who were coming more than 20 visits, and we termed this group of clients as the super users. And third, look at the explain plausibility for high frequency client visitation from distant areas based upon this concept of accessibility, healthcare utilization, which many of us in this panel and in the audience are familiar with. So I'm not going to go over all the details of the GIS here. Everybody in the audience knows it, but when I was involved in this project, I felt like I used GIS from in a very traditional way we know. We started using geocoding, the whole data preparation phase, then did some other exploratory spatial data analysis, buffer, cluster analysis, hotspots, and finally we did some modeling based on spatial regression and so on. So I'm going to focus more on the results here. So what did spatial analysis tell us more than the other health researchers who are already working in this collaboration? So when we did all this analysis, it looked like 90% of the clients lived within the 5 miles of the MMC spots, and which is not a surprise because we know proximity, close proximity plays a strong role here. But interestingly, the clients which were visiting in high numbers, so the mean utilization was around 5 to 6 visits per client, but there was a group here where they were visiting a lot, like 20 visits per client, and they were also retained in the care and in a proper care in a timely manner given by the MMC. So the question was, who are these people and where did they live and why are they coming from? So this was a classic opportunity to do our traditional health geography, spatial analysis techniques and dig deeper and find those answers. Looks like this group of people were a racially and ethnic minority population. They're undocumented and had no health insurance. So the MMC or the CHCV van was a free of service. And it did not want to see your, what documented or undocumented, did not ask those questions. It had bilingual people working, so language wasn't a barrier, which was a interesting, which is a barrier when it comes to the ethnic and racial minority groups. And the high frequency users also had several comorbidities like HIV positive, substance use, mental illness. So a lot of intersections of stigmatized health behavior was also going on with them. So what this finding showed us that they were coming from further away distance, really far away to the New Haven community. So this, we followed up with an in-depth qualitative study and we found that they did not want it to be identified in their nearby neighborhoods or nearby clinics. So they were coming further from further places in the state of Connecticut to these MMC sites. So we did several other analysis and did a comparative analysis of what was offered by the traditional clinics in those neighborhoods where there are people coming in high numbers and what additional or extra benefit that they got from this van. So typically, it's a good package of services for people who have these comorbidities of substance use and HIV. It was free. It was acceptable to them because nobody asked about their background, their status of legal or illegal status, and things like that. So it really goes into the theory of where physical accessibility is less important and other dimensions of access becomes more important. And in terms of policy, this is around the time when the ACA was becoming more popular during the Obama administration. And we had a strong recommendation to the policy that sometimes we need to see beyond physical proximity and look into other dimensions of access. So what's next for this van? So it is still there. It is working very well for the same health conditions that I mentioned. But during the COVID-19, we repurposed its activities and we distributed PPE, educational materials for the COVID-19, all the interventions, behavioral interventions, and more importantly, provided service for the postpartum visits for mothers and their infants coordinated with telehealth visits and with their doctor. This was during the time when all the hospitals were almost overwhelmed. So for this non-COVID, also important, but non-COVID situations, this kind of setting of a mobile medical clinic was in the community was very important. But the question that I have in terms of the panel discussion here, how can we do the sustainability and fund these kinds of projects? Because after this initial HIV work, which was funded by NIH, there was no funding available because all that part of innovation was done. We met all our project goals. We wrote our report when we moved on. But now the setting is there, but there is no funding. And this whole COVID-19 part was self-funded. So we looked into our networks, asked for funding. We got some generous funding from Yale, generous funding from Yale New Haven Hospital, but that's it. So for such a successful project which started, and then we don't know how to get more funding to continue this kind of project. So this is one of my questions for the panel to discuss later. Moving on to this next study here, which is about the COVID-19 second wave in India, and we all know that it is absolutely devastating and primarily driven by the misgovernance, and I don't want to go on that route. I will spend the whole afternoon here. But one of the rhetoric that you have heard along with this wave in India is this notion of undercounting, which is really happening, underreporting and undercounting of deaths and cases. So in Gujarat, which is the western state of India, a very innovative way civil society engaged in data collection. And this was from the obituaries that flooded the newspapers in a extremely unprecedented high rate during this time from April to May and continuing. So this looks like this isn't when I thought I had a mixed feeling when I read about this study, this newspaper article and then the study is, from the research point of view, extremely innovative, counting the obituaries when the government is not truthful about the reporting. Its data is coming from hard to reach places, civil society is engaged, but we have other issues as going on here. So picking up from this newspaper article, the Institute of Management in India, which is one of the premier institutes there, they did this study on how to calculate this excess mortality. What they found was that for the entire state of Gujarat, there were approximately 10 times underreporting was happening in terms of death when they compared April to May of 21 to 2020, which was the wave 1, as well as 2019, the pre-pandemic. And they did a very simple spatial analysis, and I was thinking, what if we got opportunity, or I got opportunity to get into this study, and we can do so much more in spatial analysis and using GIS to find this variable impact or variable rate of underreporting that is happening in the state of Gujarat, and which is true in all other parts of India. There's Ahmedabad, which is one of the biggest city in this state. The underreporting is 4.4, but as you go to the interior of the state, the rate of underreporting goes really high. So the question I have here is that, yes, it's an extremely innovative, my research brain gets really excited, but I also feel sad that this underreporting is happening. But how can we validate data sources that are coming from the community and other civil society units? And especially in studies, not only in India, maybe in other situations, when the data and the analysis from that data goes against the authority and the state, how can we research units or research bodies can support that? Because it will be highly contentious and there are going to be some ramifications. So how can we support that? And another question I have for the panel, discussion part of the panel is, how can we combine the big data, and this is the era of big data, with the community level data? And I'm not talking about the multi-level modeling, that we all know. I'm talking about this bigger question here about the scale issues, the methods. Do we really need to bring them together, or sometimes we do better answering of questions if things are left separate than bringing into some methodological issues? So with that, I'm going to stop my presentation here and go back to seeing all the faces, because I couldn't see what I was speaking to. I was just speaking to my screen.
Thank you, Debs. Now we see Joseph as well. And sorry about the accident, the unexpected situation I ran in. It seems like, oh, I was able to share and now I cannot again. Somehow. All right. I'm sorry about that, but let me add this. I forgot, because of the rush, I forgot to introduce Debs in a little bit more detail. Dr. Debs Gush is Associate Professor of Geography at the University of Connecticut, a principal investigator of the Institute on Collaboration for Health Intervention and Policy, and she's affiliated with Yale University's Center for Interdisciplinary Research on AIDS. And her research interests are mostly focused on the reciprocal relationship between place and health. And some cool research we already saw through her presentation. And her diverse yet complementary skill set include GIS, spatial statistics, social network, and modeling thing, and health, mobile health, which was the focus of her talk. And her research was funded by NIH, Connecticut Department of Public Health, and foundation, DPH foundations, and mutual grants from the University of Connecticut. Thank you, Debs. So we'll move on to the next one, next speaker, Dr. Michael Amsch.
Okay.
Can
okay.
you?
Yeah, we can see it.
Actually see my screen?
Yeah. If you,
I think it's Diana. When she joined in, somehow she's super kind of
okay.
yeah. All right, go ahead, Michael. Sorry about this.
I'll say slide when I want to switch slides. Okay. So I'm gonna talk about a couple of different projects that my research group has done since COVID-19 pandemic started in North Carolina in March, and one of them is on racial and ethnic and geographic disparities in virus testing, like PCR testing. And then the other one is using antibody testing to understand the seroprevalence, like who has been infected around central North Carolina. I'm just going to summarize both of them. Slide. Go to the next slide. Yep, there you go. So yeah, that's so this is I'm talking about virus testing here. So we got all of the tests from North Carolina from the state, and this is a project with the state. And so I'm just going to show the first 3 months of data, although we have all of the tests that have been done in North Carolina up till today. We just downloaded them the other day. But anyways, so at this time there were about 300,000 tests were done. The first tests that were positive were in the first, 1st of March, and I'm going to focus on the right-hand column here, and so the total test positivity in different groups, right? And so the total test positivity in that first 3 months was about 13%. Men were about 15%, women about 12%, and then the age group that was the highest was 18 to 49. It's a big group. And then when you look at racial and ethnic groups, if you see the highest group is Latinx people, okay? 66.5% positivity rate. And then I'm going to look at urban rural as well, and it was more rural, 13.5% versus about 13%. But it was pretty similar, but close. Okay, slide. So these are some time series of the 3 largest racial ethnic groups in North Carolina. The gray lines are non-Latinx white people, the red lines are non-Latinx black people, and then the blue lines are Latinx people. And on that upper left-hand corner graph, that's the total number of tests in that 3-month period. And then if you look I'm going to focus on the upper right-hand corner graph, and that is the test positivity over that 3-month period. So right at the beginning, you had to have like COVID coming out of your face to get tested. It was impossible to get tested, and that's why those lines are popping around. And then the blue line is Latinx people, and it just continued to climb. Okay, and then the red line is non-Latinx black people, and the gray line is non-Latinx white people, and so it increased, but then it declined over time. Okay, now the dashed line is 5% positivity rate, and the dashed line is the WHO standard for the goal of keeping the positivity rate below 5%, and that just was an indicator of having a good control of community spread. Okay. Okay. Slide. Okay. So I'm going to focus on. I'm not going to show you. I'm not going to talk about every. But on the left-hand side, that is the the dashed lines, the left-hand column, A and B, the graphs A and B, the dashed lines are urban, and the solid lines are rural. And if you look at the upper left-hand corner, that was the total number of tests that were done. And you can see the dashed lines in each of the three largest racial ethnic groups were all above the solid line. So testing was more urban. And then you look at the bottom left-hand graph, and you can see that test positivity, that's test positivity for those three groups, was almost always, the solid lines were almost always on top, and so it was more rural positivity rates, okay? Next slide. So these maps are showing the zip codes of different variables, and so the bottom right hand is basically the green areas are rural and the gray areas are urban. And I'm just going to focus on the bottom left-hand map there, and there's a couple of like hot spots, right? And so, but some of them are in more urban areas, but some of them are in very rural areas. Okay, there was this assumption that at the beginning of the pandemic in North Carolina that COVID was in urban areas, and so we started doing this analysis with folks at the North Carolina Department of Health and Human Services, and we found out that it was much more not much more, but it was more of a rural disease. Okay, go to the next slide. So this actually has more than just those three largest racial ethnic groups, and this is there's a whole bunch of variables in here, but I'm going to focus on the last column here, okay? And the last column is the percent positive by county for each racial ethnic group, and the red maps are non-Latinx Black people, and the blue is Latinx people. And so in eastern North Carolina, in the eastern part of this, so there were really high test positivity rates in those communities. And I'm going to talk about eastern North Carolina in a second. But in the blue, you can see that in the Latinx population, there was more spread out around the state. Okay, next slide. So this slide shows the largest non-white racial ethnic group by county, and the green is non-Latinx Black people. The orange is Latinx folks, and the blue is American Indian. So next slide. So this slide is something called a divergent index, and I'm going to focus on the one on the top. And in this case, it measures the disparity in proportion of the population from each racial ethnic group that is tested compared to the share of the population of each racial ethnic group in each county. Okay, and so a higher value basically means a bigger disparity in testing. And so you can see that there's higher disparities in the eastern part of the state. And so based on that last map that I showed you, we can see that even though non-Latinx Black people constitute the majority of the population in a lot of those counties, at least the minority population, the proportion of folks that were tested in that racial ethnic group was low, while the positivity was very high. So anyways, there was some disparities in testing versus where people were tested and who was tested versus who needed to be tested. Next slide. So quickly, a couple of conclusions. One is it was thought to be a more urban disease, but we observed a higher percentage of positive tests in folks in rural areas. And no group or subgroup in our analysis got below the suggested 5% positivity rates at all during the first 3 months, and some of them were way above. And so there were some nuances to sort of I just talked about the the sort of urbanicity, but there are lots of nuances and differences by sort of intersectional things of gender and age that I don't have time to talk about today. The big story here is the test positivity in Latinx folks, especially Latino men, was 70 to 75% from March to June. And also non-Latinx Black folks, the test positivity declined from 30% to 18%, but it was still pretty high. Okay, next slide. So I'm going to show you a couple of things about antibody testing. So antibody test is you get blood taken and see whether you've had antibodies. So if you've had COVID, and you might not have known it, but then it tells you whether you had it. So the goal of this was and this is ongoing as well, is to determine the change in seroprevalence of the SARS-CoV-2 virus in central North Carolina using remnant clinical serum samples. So basically, when people go to the hospital, they give a blood test no matter what they have, and everybody who got a blood test, we randomly selected them. And then we're going to determine, we are determining the age, gender, and spatial distributions of the seroprevalence in central North Carolina. Next slide. This basically shows the samples per month. We're getting, there's a lot of these seroprevalence studies that have been done around the country, and this is a large one. We have 1,800 samples per month in these 4 hospitals that we have at UNC in central North Carolina, and so we age stratified it based on the proportion of the population in each age strata. And next slide. This is I'm going to show you results from the first 3 months and then for 6 months. And so this basically is where, by zip code, where the samples, the number of people in each of zip code. Next slide. And then this map shows the test, the proportion of the population that was positive. So you can see that there's a lot of variation in the percent positive. So the high red values are 15% of the population. This is just 3 months into the pandemic in North Carolina. So we have every month we're still collecting data, and we are understanding how pervasive it is. Okay, one more data slide, and then I'll wrap it up. One more, yeah. Okay, so we wanted to look at the sort of seropositivity by different variables, and including gender and racial, ethnic group, and age. And I'll just focus on a couple here. And the first in gender, and this is for 6 months, and we've divided it into 3. So April to June, June to August, and August to October, in the different the 3 different age ranges. Okay, and so men, with women as the referent group, men were in that first period, the first couple of month period, was their odds ratio of being seropositive was 2 times, okay, and that of women, okay. And then I'll focus on the race, ethnicity as well, and you can see during that first 2-month period, the odds if you're a Latinx of being seropositive was 14.5. I mean, it's huge. Okay, and then for the entire period, it was 7.77. So the last column of this data set actually has the whole range. Okay, 7.77. And I'll pop back up to the non-Latinx Black row, and you can see that in total, 1.8. Sorry, I don't have a pointer, but I hope you can find this. But 1.8 odds of non-Latinx Black people being seropositive versus non-Latinx white people. So next slide. It's my last slide. So there were and by the way, there were a lot more infections than the cumulative total cases that were reported at this time. So there were a lot of people, there's a lot of asymptomatic people, Latinx people had the highest odds at 7.77 overall. It's massive. And odds of 1.8 overall for non-Latinx Black people. And so this increased odds of seropositivity along those racial ethnic lines, it shows what we've all known, but it actually documents it, is there are extraordinary disparities in not only testing, but in who has gotten COVID-19, and we're just starting to realize them. So next slide. Just want to recognize on the first slide, there were a whole bunch of authors, including somebody who's with me here in this hotel in Gabon right now, Varun Goel, and then there's a whole bunch of people here that were not on that first slide that were part of this. There's a lot of people. I didn't do that much of the work. They did it. Anyways, that's it.
Thank you, Michael. It's a very interesting and timely topic. I'm sure there will be quite some questions later. So then we will move on to the next speaker, Dr. Russell Kirby. Dr. Kirby, so you're fine. You don't need me to share, do you?
Just open up the share audio. Let's see if I can.
Okay, I will stop sharing and then you see if you can. So quickly, let me do a very brief introduction of Dr. Kirby. Dr. Kirby is a distinguished university professor and Morrell Endowed Chair, as well as strategic area faculty lead for population health science in the College of Public Health at the University of South Florida. And Dr. Kirby has a doctorate in human geography and a postdoctoral Master of Science in Preventive Medicine Epidemiology, and has worked in state public health agencies, academic medicine, and academic public health since the early 1980s. Much of Dr. Kirby's work is multidisciplinary and involves collaborative teams focused on maternal and child health, as will become evident in today's brief presentation. So Russell, are you good?
Okay, right, so that's a title slide. So let's go to the next slide. Okay, and I just have a disclosure with it, just to let you know that I used electrons mostly in the talk. Go to the next. Always put a conflict of interest in. I don't have any conflicts of interest related to this, but I should let Michael know I come up to North Carolina every year to go to a bluegrass festival. And then I am an epidemiologist as well as a geographer, and I always like to include this cartoon from the New Yorker from after 9/11, where the two ladies are talking to each other, and one of them says, "It was really brilliant of you to have invited an epidemiologist, but of course nobody ever invites me just because of that." Okay. And there, okay. If we could go to the next slide. Yeah, there, okay. So this slide is the only slide I have in the talk that has any data on it. And it's not my work either. It's actually an article from the American Journal of Public Health a few years ago. But what this shows is Flint, Michigan. And I think there's somebody who might need to mute. We've got some feedback. What this shows is basically the exposure to lead in Flint, Michigan, broken down into small areas. And the reason I put this map here is to kind of illustrate that there's a lot of things that are going on when we see them. I talked to an audience of geographers about this, but at one level it's a pattern. I mean, it shows us the current state at the time of the map for the distribution of high and lower exposure to lead, but it also encapsulates a whole variety of processes that have led to this pattern. and there are many things that are incorporated here. We can definitely see aspects of structural racism. We can see aspects of justice. We can see, the long-term effects of public policies, and a lot of social processes are involved in this as well. And if we want to truly understand what's going on at the community, within the community, we have to be thinking about all those different dimensions and not just be looking at the environmental exposure that we have seen in this particular map. If we go to the next slide, so when I think about GIS and community health, and as a disclaimer, I'm the director of a PhD program in community and family health, and I'm a geographer as well as an epidemiologist. But I think in order to really think about GIS and community health, our work has to be multidisciplinary, and it's very important to look at whatever subject we're looking at from different perspectives. Ideally, we should be thinking about things in a manner that's population-based, and I think what Michael was showing us is an example of using population-based data to look at different phenomena in terms of health and disease, but we need to be thinking about it in that way. It's very important to look at a wide array of different data streams or data sources. There's an enormous amount of data that's available from public sources. I have to tell you, I'm working with a student right now who has a small grant to study the health and economic impacts of Hurricane Michael that hit the panhandle of Florida about 2 years ago. And there's an enormous amount of data that one can obtain. The challenge is to put it together into a framework where we can actually make sense out of it. And that requires us to really carefully about data structures so that we can have our data arrayed in a way that enables us to analyze it in whatever mechanism might make the most sense. It also is important that we have the flexibility to integrate data from a variety of different sources. And very frequently, GIS is the enabling technology that allows us to bring data together from a number of different sources. Increasingly, I've become interested in how to do mixed methods research within community health, and in particular thinking about how to incorporate GIS into mixed methods research. So when we think about mixed methods research, we're talking about research that has both quantitative and explicitly qualitative components that then are triangulated or brought together in various ways. And the voice of the community is essential. If one study to identify the areas that are highest risk for lead exposure in Flint, Michigan, and doesn't get into the community, to the people who are exposed and get their views and get their perspectives, you're going to end up with an incomplete end product. If we go to the next slide, and actually go one more, that was just an intro kind of, no, one more after that, that's good. So in the work that I do, we think about several different frameworks, and one of the frameworks that we use a lot is called the LifeCourse Framework. And there are many books written about the LifeCourse perspective, and I will just briefly encapsulate it. But the whole idea is that different groups within our population have different opportunities and risk profiles. And what this is showing us is that if we compare, for example, a white male with an African-American female, the number of stressors that they have differ greatly, and the opportunities differ greatly. And if we're interested in coming up with strategies that improve outcomes for all, that reduce disparities while still making the best outcomes for everyone, we're going to need to focus differently on these different groups in terms of the kinds of health promotion strategies and risk reduction strategies that we choose to use. If we go to the next slide, the next slide is also one looking at the LifeCourse paradigm in a little bit different way. But the key thing about this is that there are overlapping concentric circles that represent different issues that we have to be thinking about that vary in importance depending on where a person is in the overall of life. And we have things at the outer circle, looking at the culture, the history, and time and place. Within that, we have the social integration that the person has with the community and social supports and so on. Then we have human agency, the things that the person does themselves. And then the various things that happen in people's daily lives, and all of those overlap with one another, and we have to be thinking about how to measure and integrate across them. If we go to the next slide, this slide basically shows the socioecological model, and in this case, looking at African American women and the experiences that they might have. But again, the socioecological framework is one that people use a lot in community health research. And it basically posits, similar to the diagram I just showed a moment ago, that there are overlapping domains that each have their own influences on the individual experience, and ranging broadly from the historical context, inwardly to society and politics and so on, and ranging down eventually to the family and the individual. And these affect individuals in different ways. What we do know is that the social determinants of health are extremely important to be thinking about in studying whatever phenomenon we might be interested in terms of health states and diseases and health conditions, and have to be thought about in a very thoughtful way. And again, it typically requires having a multidisciplinary, usually multi-level kind of a framework in order to do that. And of course, the great news is that GIS is a wonderful environment for actually building kinds of models and evaluating them. If we go to the next slide, which I think might be my last substantive slide, GIS I really do see as an enabling technology. It's very useful for data visualization, and frequently the things that we see aren't exactly what we expect, but they allow us to ask additional questions. GIS is not typically going to be the confirmatory tool, but it is very useful for hypothesis generation that can lead us to potentially doing things in a very variety of different ways, and potentially to enable us to build more comprehensive models. Again, I mentioned it's useful for multi-level modeling, and it's also useful for both for looking at phenomena in space and also in space and time. Obviously, challenges in terms of the amount of data we might have and the kind of data integration we need to do in order to do our analyses. I was talking with a colleague yesterday at another university about research looking at air pollutants and pregnancy outcomes, and we got into a very interesting discussion about how one actually pulls data from environmental monitors and remote sensing, and to actually make it useful for a study like that. But I just wanted to end with the point that all the work that we do here has to be done scientifically. We have to always be concerned about the quality of the data that we're working with and its veracity, liability, and so on. And then we also have to think about the unintended consequences of the work that we do and try to avoid them if at all possible, and incorporate the voices of the communities that might be involved in whatever research we might be doing. Let's see if I have one more slide. I think it just has contact information. I'm happy if anybody wants to email me or chat further, and I'll be around for additional questions. So thank you very much.
Thank you, Dr. Kirby. That was wonderful hearing. Actually, I really will follow up. I'm happy talking about potential limitations of GIS. So GIS can enable a lot, but we need to be careful. So I believe we're going to have time to follow up on that. And now, for the sake of time, our next speaker should be Dr. Let me quickly introduce our next speaker, Dr. Sarah McLafferty. Professor McLafferty is with the Department of Geography and GI Science at the University of Illinois and Urbana-Champaign. Her research uses GIS and spatial analysis to investigate place-based inequalities in health and access to health care for women, immigrants, and racial ethnicity minorities in the U.S. Her books include GIS and Public Health with Alan Cromley and GIS and Environmental Health with Juliana Mente. And Dr. McLafferty is Associate Editor at Health and Place. Sarah.
Okay, thank you. And Joseph, could you mute yourself? Just to be sure this works. Okay, I'd like to follow up on some of the themes that have already been raised, but look at them from a broader perspective. So next slide. So my main question is, how can geospatial perspectives and methods contribute to improving community health? And next slide. I have a lot of slides. So I'd like to argue that there are three broad categories of ways that geography and GIS can contribute to improving public health in communities. And I refer to these as spatial targeting, spatial tailoring, and then finally spatially generating. So I want to talk about each one of these in turn. So next slide. So spatial targeting is when I focus our resources and public health interventions in the places or areas in which they are most needed. And geospatial methods have been crucial in spatial targeting. I mean, our hotspot mapping, heat mapping, cluster detection, all of these methods kind of underpin the process of spatial targeting. Next slide. Next. And spatial targeting has a long history in public health. For example, the smallpox eradication effort was really rooted in spatial targeting as they tried to bring the disease to a close. And we see the same thing in current efforts to eradicate polio. So in infectious disease control and eradication, spatial targeting is very important. Next slide. And spatial targeting has also become kind of de rigueur in spatial analysis studies of health issues. So many articles that I review as an editor have like a sentence or a paragraph in the conclusion about how the results can be used for targeting. Next slide. And then we're also seeing a lot of use of spatial targeting in current efforts to control COVID-19. For example, the city of Chicago is targeting vaccination efforts in like 13 communities in the city that have very low rates of vaccination. And we're seeing similar initiatives in places like Toronto, New York, Boston. Many cities are doing spatial targeting in an effort to control COVID. Next slide. And there's also a really interesting study, and this has not been peer-reviewed or published, so I probably shouldn't have included it, but anyway, but it shows using simulation modeling that spatial targeting combined with demographic targeting based on age can be very effective in vaccination efforts for COVID. So next slide. However, spatial targeting has limitations and there are important issues in trying to use spatial targeting. The modifiable area unit problem is very relevant, and I've shown there Mark Monmanier's wonderful example where he takes John Snow's cholera map and then creates aerial units or aggregates the data to aerial units, and you can either see the hotspot of cholera cases or it completely disappears depending on how the aerial units are defined. We also need to think about the uncertain geographic context problem, which means that, for example, we might have a hotspot of COVID-19 based on workplace exposures or based on exposures at a church or somewhere like that. Next slide. And then there are also social issues with spatial targeting. And I won't elaborate on these, but things like hidden populations, or we may have hotspots within cold spots. And of course, there are issues of stigmatization when we display hotspot maps of health phenomena. And those are some of my maps on bedbug infestations in New York City, which could end up stigmatizing neighborhoods. So given these issues, I think we need to think more broadly about how geography and GIS can contribute to community-based public health. And so next slide talks about spatial tailoring, which is when we do place-specific customization of interventions. So we tailor public health interventions to the distinctive characteristics of communities and local populations within them. And spatial tailoring requires a detailed knowledge of the local environment, people's interactions, social interactions, mobilities, and all of the processes that put people at risk of ill health. So these are kind of multi-layered, spatial tailoring is multi-layered and multifaceted. Next slide. And here's an example. If you could click and click, Yongmei, there, I forgot there's an animation on it, so just click twice. Thank you. Anyway, this shows 2 hotspots in New York City for low birth weight. And both are hotspots, but they differ tremendously in population composition in terms of the race and ethnicity of people who live there, and also in terms of environmental characteristics like transportation, access to services, and so on. Next slide. And so we can think about using GIS to sort of incorporate all of these different layers of information about place and pull them together to gain a better understanding of both the contextual and compositional characteristics of places. Next slide. The final contribution I want to mention is what I call spatially generating. And it's not the perfect word, but here I'm referring to community-based interventions and including community input in the design of interventions. And spatial generating involves bottom-up and participatory processes that incorporate local knowledge and local concerns. It also involves allowing community members to ask questions related to their own health. And here we could think about participatory GIS, critical GIS, qualitative GIS, ways of bringing in different kinds of data and interactions to GIS. Next slide. So here, one example, this is from some very old research I did years ago, where we worked with a community group on Long Island about breast cancer. And the community group actually collected their own data on breast cancer incidents. So they went door to door, surveyed women to find out who had had breast cancer or not. And so what we did was to let the community members ask their own GIS questions. And one of the questions they asked was, are breast cancer cases clustered among women who live at the ends of water mains? So, you know, you might say, well, it's not scientific or whatever, but it was something the women were concerned about and wanted to know about. So next slide. So we use GIS to create buffers and identify homes that were at the ends of water mains. And then we compared the breast cancer incidence for women living at the ends of the water mains and those outside. And we actually found that the breast cancer rate was higher among women who did not live at the ends of the water mains. So their hypothesis was not confirmed, but they really appreciated the ability to ask their own questions and have us as scientists provide answers for them. Next slide. And then this is another example from Kirsten Byer's work where she was looking at cancer in Iowa, and she asked community residents what they thought might be environmental and contextual factors contributing to the high rates of cancer there. So next slide. So again, I want to emphasize that targeting, tailoring, generating, these processes can incorporate concepts both of space and place. So they're not just spatial, but also place-based processes. And each of these can inform the other. We can use generating to target and to tailor and so on. So I view these three as being sort of mutually interacting and reinforcing. Next slide. And so just to conclude, I believe firmly that geographic methods and concepts and perspectives can help greatly in efforts to improve community health. And I think these fall within the three broad categories of targeting, tailoring, and generating. And much of our GIS-based literature has emphasized the targeting, but I encourage all of us to think more broadly and about tailoring and community generating of GIS queries and insights as we move forward. And I think some of the previous presenters provided good examples of this. So that's it. Next slide is just to say thank you. And I will quit.
Thank you, Sarah. Spatial targeting, tailoring, generating, and we certainly can follow up on the related discussions during our Q&A section. And now Joseph, Dr. Opine is our next speaker. So Dr. Joseph R. Opine is a professor of geography and academic associate dean of the Robert Toulson Graduate School at the University of North Texas, where he has been teaching and doing research since 1992. Currently a member of the National Council of the AAG, Dr. Opang has served as chair of the Africa Specialty Group and the Health and Medical Geography Specialty Group of the American Association of Geographers. Dr. Opang's research focuses on spatial analysis and modeling of the spatial patterns of disease and health services.
All right, thank you.
Sure, go ahead.
So I want to see you. Okay, good. Okay, that's good. Thank you. So one of the things that wow, I can hear the echoes too loud for me. Many of us have, we always, at least in Texas, we depend on the ozone alert. Ozone pollution is a big problem, and pollution overall has huge implications for healthcare. And frequently, we plan our lives for those people with specific comorbidities. We plan our lives based on the ozone alerts, just like we have the weather forecast and we decide whether we're going to go out today or we are not going to go out today. Now, the ozone alert is based on pollution sensors that have been placed across the region. And the data generated from these pollution sensors informs whether we have an alert or whether we don't have alert. Now, it's a very, very basic geographic problem. Sarah, going back to our location and location modeling days, you have a certain number of monitors, sensors, and the coverage of those monitors determines how much information you can get. The location of those sensors also influence whether you have adequate coverage or you don't have adequate coverage. And so we might say that overall there is not an ozone alert today, but we don't have coverage in the areas where there is ozone pollution, maybe where we don't have any information about the ozone that's out there. So the research we set out to try to look at was, for the Dallas-Fort Worth region, where are the ozone pollution sensors? Are they enough? Do we have effective coverage of those ozone pollution sensors? In other words, when we have an alert, are there people who are not being covered by that alert? Are there people who are experiencing high ozone pollution and we are missing that? And so that is what we set out to do. We use the CDC Social Vulnerability Index, and we're doing some simple tests to see the areas where you have ozone pollution sensor coverage versus those where you don't have any coverage. Are the characteristics of the people different? So those are the kinds of questions we're asking. And we know enough about ozone as a pollutant. So we look at the Dallas-Fort Worth Metroplex. This is what we see. We have 10 regions in the Dallas-Fort Worth Metroplex, and the population is growing rapidly from about, right now, from 1990 to 2010, the population grew by to about 7.8 million, and it has grown very rapidly recently, so that we now have about 6.37 million, and it is expected to continue to grow even further. Now, the highest populations are centered in Dallas and Tarrant County. And then you have, of course, the surrounding counties, Denton, where we have Wise County and the others. So overall, we have a relatively large concentration of population in this area. Now, let's look at the, come on. Okay. So what we have here is the ozone monitors, I mean the pollution sensors. And most of these sensors were placed 2000 or before. The idea here is that each of these sensors is covering a certain radius. And so if there's an area here, such as the Northwest in West County, where there is no sensor, then we don't have adequate information about ozone pollution in that area. If we have some areas that have less coverage or inadequate coverage, it creates a problem for us. So overall, we have 17 total ozone sensors in the 10-county region. And about 82% of them were placed before 2000. And despite the rapid growth, despite the spatial extent increase, only 3 sensors have been placed after 2001. The interesting thing is that those 3 sensors were placed in specific locations that did not seek to expand the coverage that is provided by the existing set. And so for, again, Sarah, I'm going back to your spatial targeting, spatial generating. The whole idea of using your simple location allocation model, looking at the existing coverage of the existing sensors, and then looking at the gaps in coverage so that we can try to make sure that we have adequate coverage for all the people, so that our ozone alert is providing useful information for all the people. That is not what was done. And so when you look at the coverage, what you find is that some areas have very, very little coverage. The other interesting thing that we need to think about is what is happening on the environmental surface itself. Dallas, I mean, in Texas here, we're known for fracking and other wells. Now, we have all kinds of wells, and all of these wells also somehow drive the ozone pollution. Wise County here, which is northwest of the Dallas-Fort Worth Metroplex, has very, very high rates of wells, especially fracking wells. Interestingly, we don't have even one ozone pollution sensor in Wise County. In contrast, other areas, the older parts, the areas where original parts of the Metroplex have a lot of coverage. The point we're getting at is that there seems to be a spatial mismatch. The areas that probably have a high concentration of ozone pollution doesn't have the sensors to be able to determine the ozone pollution. Okay. Now, what we did was we looked at, okay, so Texas Environmental Pollution, TCEQ, has set, and even with the Environmental Protection Agency, they have set specific radii. So this is the coverage. So we want to make sure that every sensor, this is the spatial scale. So what, 4 kilometers coverage, 6 kilometers coverage, 20 kilometers coverage. So we looked at these standards that they have set for themselves and said, let's evaluate the existing system of ozone pollution sensors and see how much coverage we have in each of these locations. And what you see very clearly is that there are huge gaps in coverage. And the older parts, the original core area of the Dallas-Fort Worth Metroplex, you have quite effective coverage. In other words, when we have the ozone alert that comes out, if you live in this area, it is an accurate prediction of your risk of exposure to ozone pollution. But when you're living out there in an area where the coverage of the sensor is not reaching, where we have gaps in our data, then the alert doesn't necessarily affect you as much. In other words, you are being exposed to ozone pollution that you are not aware of being exposed to. We then took this basic information and then we went in to see what are the characteristics of those places where you have limited ozone pollution coverage. And we used the Social Vulnerability Index, all the variables in there, And we found some interesting things. We found, for example, that the areas with mobile home housing, areas with high per capita income have ozone pollution monitors. Areas with mobile home housing are less likely to have pollution sensors. Areas with multi-family housing, especially in the downtown, in the core areas of Dallas-Fort Worth area, tend to have effective covering, but those areas where you have more vulnerable populations do not have the effective coverage. So we have data gaps in the areas where the most vulnerable populations are living. So the characteristics of people inside of the spatial scale, that is inside of the coverage area, were statistically different from those of the people that lived outside the coverage area. We found that frequently the areas that were not covered were occupied by mobile homes. It's not the rich and affluent who live in the areas occupied by mobile homes. And the variable that predicted coverage most frequently was per capita income and multi-unit structures. The point in here is that we need to think about how to effectively spread the ozone pollution sensors so that we have adequate information to protect people who are dealing with asthma and other morbidities. Specifically, this is where I come back to what Sarah was talking about. Sarah was talking about using GIS to generate and target interventions. Okay, so what I'm thinking about here, in fact, my student who did this work, Carrie had a small ozone monitor in her home, and she was collecting the data. So I can think about crowdsourcing ozone pollution information, which can be pooled then to provide more adequate coverage. These ozone monitors are expensive, and we cannot count on the state or even the city to provide additional sensors in these locations where there's not enough sensors. So perhaps allowing and finding a way to pool the citizen-generated ozone pollution data would be an excellent way of supplementing this. Areas with high mobile homes likely to have no coverage, and it is important that we try to improve coverage for these people so that we can overall reduce the risk of exposure, the risk of pollution for people that have these complicated situations. I think that's a good place to stop, and then we can address the issues in the discussion in the question and answer time. Thank you.
Thank you, Joseph. Very interesting topic. Actually, I'm personally very interested in that because one of my PhD students is developing a proposal which is very relevant, air pollution quality and cross-sourcing data. So I want to thank all the panel members. And I'm not sure, probably Enki, you're still having trouble because I don't see her back here. Now I see 4 panelists here, and Russell, okay, now Dr. Russell Kirby is back as well. So thank you. Now we see all the panel here, and I know we're running late, but probably we can afford to talk a little bit. I'm saying 7-9 minutes, because the next session is going to start at in like I'm going to say 2:30, 3:30 is time. So I do see again Enki is still not back. I saw a few questions asked through the chat function here. So I'm just going to read a couple of questions. And this question is, I believe, for Michael Amch. And the question is, first of all, thanks for the interesting research. And the question is, are there any hypothetical reasons for disparities of positive areas among different races, and how the results may be used to help control the disease spread?
Yeah, so I chatted, I sent a message back about that, and so I'll just give an example. So in North Carolina, we work with the North Carolina Department of Health and Human Services on this project, and you know, we actually have a really great government in North Carolina, at least the governor and his people. Not so much the legislature, but this is being taped. I'll probably, but anyways, there is a disparities group within the COVID-19 programs within the North Carolina Department of Health and Human Services, and so using this information to try to target people from groups that are underserved, right? And so this is kind of not my thing, but maybe people like Sarah have more experience with it, but we've been involved with communicating with people from community groups, and Debs has more experience than this with me too. But community groups, and there's something called Latinx 19, and there are particular challenges for like getting folks tested. Like, what if you're positive? What do you do with that information? You really need money, right? You need food and things like that. So you can't stop going to work if you are like working, in different, essential jobs like, lawn care or building, roofs and things like that. So anyways, there's been some work with community organizations who know best how to serve their communities, and so that's been something that we, as the sort of empirical scientists, have provided them with information, and we've had lots of meetings with folks, and so they seem very interested in having us. We know how to deal with data, and they know how to work in their communities. So it's been really impressive to me, and they're really great people, both at the state and in these groups, and I think that they've made a lot of progress.
All right. I was muted. Thank you, Michael. I see the next question. I believe this one is for Russell, Dr. Kirby. So, well, first, thank you for the introduction and the talk. The question is, would be really nice to see your evaluation of how public/community health is driving the advancements of GI science with new research opportunities challenges in COVID, for example, in COVID-19 responses.
Yeah, no, that's a really good question, and I don't know that I have a concrete answer. What I would say, though, if we disregard the COVID part of it and talk more generally, I think what's really important is to bring together researchers with different backgrounds, and the fertile ground of them working together can make some major advancements. What I have seen is, I have many colleagues who don't have any training in geography and know a little bit about GIS, who do these kinds of applications. And likewise, I've seen a lot of geographers who don't know much about health do these kinds of studies. What is, we need to bring the two together. And many of our larger universities still operate more, in public health we use the term silos, but I always was struck back when I was, in an earlier era. I knew there was this place called Johns Hopkins University. Maybe you guys have heard of it. Very well known in public health circles, usually ranked number 1 or number 2 in public health, and has a geography and engineering department ranked in the top 10 in geography. And I would never see collaborative projects. There were all sorts of small area studies. You know, Alan Gittleson, who kind of pioneered the whole idea of small area analysis of health data, was at Hopkins, for example, and didn't get any input from geographers and spatial scientists, and vice versa. And we really need to bring people together, and not just the people who have the theory and content expertise, but also people who really understand the context as well. And it's in this day and age, the idea that anybody does any research as a solo, single authored paper, it doesn't. But building multidisciplinary teams that enable one to really, capture the essence of an issue, from a variety of different perspectives, where the sum is greater than the parts, is really important. And I think that's true also in terms of how we look at COVID as well. Okay, Sarah, you might have some comments about that from your.
I think you were talking, Yongmei, and
there we go. Okay, that will explain. Yeah, go ahead.
Okay, no, I was just, I did not notice I was muted. No, we have only 4 minutes before the next session need to start. So we're really out of time. I do really thank you on behalf of Enki as well. Thank all of our panelists for joining us today. This was really a great session with all the discussions generally how GIS and can be used to help us to work on community health issues, and also the caveat of GIS. We must be aware of that, and critical GIS public participation can all contribute. And that's the first talk mentioned how we can make some of the approach sustainable. Right, and the big data and GIS, all the challenges. So actually, Enki and me will be working with annals, and possibly we may be able to follow up with special annals. Annals of Aging does not have a special issue, but possibly we're considering a forum so that we can put together a group of short paper with the focus theme, GIS and community health. So we will certainly follow up on that, and we will reach out to our panelists, and we will also reach out to our audience. And if you guys and audience as well are interested in following up on this discussion, please do feel free to reach out to me and Enki. With that, I would actually love to give every panelist 1 minute to give a concluding talk, but we don't have that time. I just want to thank you again for this wonderful session, and we'll be in touch. And we have a lot of questions, interesting questions. We will follow up. Thank you.
Okay.
Thank you.
Thank you.
I just want to say I can't wait to see you guys in person. Is it New York?
I absolutely agree. It'd be great to be in person. Yeah.
Yeah.
So if any of you guys happen to be coming down to Florida and you come around Tampa, let me know. I'd be happy to visit with you.
Looking forward to meet all of you soon.
Thank you.
Thank you, everyone.
Okay, bye-bye.